So I'll be talking about bifurcations in chip. So far, all the nice talks were related and kind of go together. In some cases, you will have in left main, you have bifurcation CTO. Chip, obviously, it's not only about the anatomy, it's also about the patient, the comorbidities. It's also about the skills of the team, dedicated team. And when you put this all together, especially with dedicated team, you should have a good success in the program. I just want to get my slides there. Not my slides. It should be bifurcations in chip. Thank you. So this is a picture of New Orleans, island next to Quebec City, where I did my fellowship. In November, exactly this time of the year, you have apples still there in preparation for cider. They need 3 days of constant temperatures minus, and a lot of labor, a lot of planning to make a good product. So very similar to what we get in chip, a lot of good planning with good team. And as I said, it's complex anatomy, as we discussed, complex patient, and quite often it's poor LV function, bad kidneys, aortic valve disease, mitral valve, anemia, peripheral vessel disease, very important for access, and obviously the skills. And sometimes these things can coexist, and intravascular imaging is so important to plan properly. Nowadays we have lots of tools, but the main tool is obviously imaging. And bifurcation PCI skills are essential. All of you will have them. CHIP and CTO PCI, they're all part of the contemporary complex PCI, which is now a subspecialty of interventional cardiology, similar to structural. And that involves dedicated team, tools, and of course, indicated patients. But when you put these things together, bifurcations in CTO and CHIP, this becomes a challenging subset of lesion to treat. Bifurcations in CTO are quite common, up to 25–30% of cases. This is a single operator study, so it's a bit outdated, but still it tells you that presence of bifurcation in complex CTO lesions has more bad outcomes if not done properly. I like this classification when you talk to your colleagues about the bifurcation in CTO, depending on where it is located. And the most important thing in bifurcation in CTO in complex cases is the presence of a wire in your side branch. It's a powerful predictor of success. What happens if a branch is lost? It obviously depends on the size of the branch, on its relevance. Is it important? Can the patient with low ejection fraction tolerate this during your procedure or even in long term? And back to my original slide, sometimes branches are not important, nothing will happen, but sometimes they could have long-term consequences. On a follow-up, usually in CTO PCI, loss of bifurcation branch is bad. And you can see in this study from China, in the second group, when there is a suboptimal recanalization with persistence of significant side branch occlusion, you can see that at follow-up, this group will have worse outcomes. And when we talk about mechanism of side branch occlusion, of course, like in any normal bifurcation, it could be plug shift, it could be carinal shift, but in CTO PCI and in complex lesions, it's also a new term called subintimal shift. This is usually a bit different, cattle efficient, treated differently. So imagine if you wire the subintimally opposite the branch and then you dilate there, and sometimes we obviously don't do injections in antegrade escalation and you don't use IVUS here, it can lead to the branch occlusion. And that particular subintimal shift requires stenting versus provisional with ballooning, with plug shift or carinal shift sometimes. Common principles in CHIP obviously requires a good strategy, less contrast, less procedural time if it's possible. We have to decide if we can simplify the case by doing provisional stenting. should we do everything at once or should we do staged? It also depends if you have mechanical support through the case. Double scrap, as mentioned, it's very important. We have dual operators, or can you refer this to another center where skills are more advanced? Bifurcation assessment, obviously, in chip is the same as in normal bifurcation. Median is what we use. It also obviously depends on your experience and your desire to learn. Syntax follow-up published this year at 10 years eventually concluded that bifurcation PCI has worse follow-up. It requires more revascularization at 5 years, as you can see, and all-cause death also at 10 years is much higher versus those where bifurcations were not treated. And you can see also in the same syntax trial, follow-up at 10 years, PCI requiring bifurcation versus no bifurcation has more mortality. And you have to remember when the syntax trial was done, the imaging was useless, obviously the stents were third generation, etc. So many questions there, but just to give you a bit of some idea. And obviously in complex PCI referrals, when it is surgical turn down, when you know the surgeons are not going to fix it, does the syntax score has any relevance? Complexity of the bifurcation obviously assessed through main branch and side branch. We all know that. Dr. Chen from China did definition study, which was followed up by another 3,500 patient validation in definition 2. I think this was already shown by one of the presenters. It's basically they do decay crash, as you know, as their preferred choice in complex PCI lesions, and they show that these results are better long term. Obviously, they are high volume operators in that area. We always try to simplify approach. If provisional can be done, it's great. And of course, if not, then what kind of two-stent strategy to choose. But what's important is we should encourage ourselves is to do imaging. Imaging, as we know, in PCI has good outcomes long term. It's no question about that. In this case that I did in my first year after fellowship, where I perforated left main and put a papyrus stent and did penetration of that, fenestration, no imaging was used. So that's called IVUS regret. And of course, as mentioned in my practice, I try to do provisional if it's possible. So I'll go through a few cases. In provisional, obviously, you have to wire a distal strut if possible. So this is a case about 82-year-old lady with symptoms for 1 week, and she's from very far away, presents with shock and poor LV function with bad MR. And my colleagues do a diagnostic angiogram through the night, and that's, you can see, shows a couple of bifurcation, left main and first diagonal bifurcation, very calcified. And right coronary is quite bad. So she was referred she had balloon pump inserted and referred for surgical opinion. And surgeons came the same night and rejected her for many reasons. So the next day I did a 6 French guide, and I was not able to do imaging because the IVUS would not go anywhere to assess, but at least I saw the left main, and then did simple ballooning and stent. And then I was able to put the IVUS through the diagonal, at least to assess the stent. I was quite happy with that. And in this case, because of the shock situation, patient's unwell, I decided not to treat the second bifurcation, because that may potentially have bad outcomes for the patient. So I brought the patient the next day. She's still on balloon pump, more stable. And I did a rota PCI of the right coronary artery and put 1 or 2 stents there. As you can see, a lot of nodular calcium that will just persist there. And then I did a staged PCI at 2.5 months. Originally it was with 1.5 burr, but I will not show it here. I reserve it for complication sessions. But the proximal left main stent came out completely on that 1.5 rotor. Usually I do protect the stent, fresh stent, with a guide extension and do rotor through that, but I didn't do it here 2.5 months. But anyway, beyond that, you will see that there is no stent anymore there in the proximal left main LAD. And then I used 125 burr. It took a bit of time to cross it. Then I was able to do IVUS and put a couple stents. So this is 2.5 months apart. Her LV function improved to 50%. Her MR is still 3 on 4. This was about a month ago. We'll see what we do with that MR later. So T-stent strategy is also used in my practice. And obviously it can be TAP, depending. It can be conversion from provisional. This a case we did actually in NZ Live in Australia also 4 years ago. Patient is quite unwell with poor LV function, and this is quite significant left main LAD disease, circumflex ostium and big diagonal. And as you can see, a lot of calcium on these injections. So what is the plan here? We decided to treat the right coronary artery. There were 4 stents in total. Provisional bifurcation treatment, simplified that, but we did it offline. And we use obviously Impella. And then 1520 burr to open access to the LAD and treat that calcium. That time we didn't have orbital, obviously, and we didn't have shock wave. And then I did a hairpin technique, reverse wire technique, through the dual lumen catheter to get access to the side branch, and then dilated it with Corsair and did ballooning. And then stented this mid-distal LAD, then diagonal was ballooned in preparation for another stent in T-stent fashion. Then further treatment of LAD and treatment of the circumflex. This was an 8 French guide, so I was able to do all the techniques. And then you can see OPN was used, so special complex PCI equipment. So both of these bifurcations, to simplify, I used T-stent, and that was final result. 4 years later, patient is alive. And that was a very long case. It was in the 2nd year of my fellowship, so, and I think we did well there, before and after. And this left system. And of course, when we talk about really complex bifurcation, especially in left main, culotte and decay crash, with more evidence now towards decay crash, especially with the help of Dr. Chen and his team, is very valid. And standardization is very important step by step. So in culotte, similar to non-chip interventions, it's very important to know what styles you have, what brands of the stents before planning, because not all of them will go to the certain diameter. So this is an elderly patient. Quite often those chip patients will be old, as you know, with poor LV function, was chosen for intervention. See, here you can see quite calcified proximal disease. And here I decided to do culotte strategy, preparation with rota, stent, and then left some place before ostium for completeness of the bifurcation later. And then did treatment of the circumflex with rota, assessed everything with imaging. That's the second stent there, pod preparation, then rewiring, kissing balloons, and then put another stent there, and final result. So another important technique I learned recently from Swiss operators is sidecar technique. You probably know that. I use it quite a lot, especially for distal ride, where you used simple semi-compliant balloon, fenestrate that, bring your wire of choice for your distal target, and bring it like I'll show you. This is the case before and after with the culotte. Very calcified, where I used shockwave, rotor both limbs, and I use this technique to bring a balloon down and release the second wire. So the second wire is inside the balloon. You push the balloon forward, release the wire, and then bring a balloon all the way back. But you have untwisted wire that you can use for your bifurcation. Decay crash evolved significantly since original Colombo publications a long time ago, and I will show decay crash in my case presentation later today. European Bifurcation Club is the organization that keeps moving forward, and you can see here in 2020 importance of the side branch ostium coverage, and about decay crash, and then 2021 new recommendations. It's all these papers are available. Pot important, final kissing important, etc. And finally, I would like to talk about drug-eluting balloons. I use more and more in de novo lesions rather than just in ISR. This original publication from Australian group a long time ago, 7 years ago. So this 81-year-old man I just did last week with typical symptoms of CTO, poor LV function, and this is his angiogram. Significant bifurcation problem, lots of calcium. So I staged him, brought back in 2 weeks' time. And he has a bit of support already from the right side. So it's kind of functional CTO. So I crossed antegrally to the diagonal, rotated that. Then I did the same IVUS assessment, then rotated the LID, IVUS of that. And then use drug-eluting balloon in the side branch. Then I was control of that to make sure everything is good without any injections. And then stented short stent in the LAD. Optimize that. So again, to make the case simple without two-stent bifurcation treatment in calcium. And this is my final slide. Thank you very much. If any questions?
Thank you, Rustem. Very good talk. Now, one quick two questions, among the two-stent techniques, generally now we feel that we have evidences that decay crash is superior to the rest of the techniques, including culotte. Now, in a chip case bifurcation, do you go for more of decay crash in your practice, especially left main bifurcation? That's one thing which I would like to know. Many a time, now, if you could get away with stenting technique with lesser steps, I used to do that and then get the result, and I confirm with the intravascular imaging that the result is quite acceptable. That's number one question. Number two, as you have pointed out, increasingly we are also using drug-coated balloons, making the procedure less complex in otherwise complex situations. How do you choose for a drug-eluting balloon on the anatomy or functional, and how you assess the completeness of the procedure of drug-eluting balloon in a branch?
Thank you. I'll start with the second question. So in this case, for example, when we're dealing with ostial lesions, where the lesion is less than 5 millimeter, where you can do provisional in the first place, but on imaging I see quite significant disease of the ostium, I use quite often drug-eluting balloons, and sometimes I require to cut the ostium with cutting balloon, or here as with rotor, and that way after ballooning DEB, I do IVUS again to make sure there are no major dissections, and then before I close the access with a stent. And in de novo lesions, as you know, long CTO, for example, of the LAD, the main segment of CTO, quite often I treat proximally with stent and mid-distal vessel with DEB, again, with IVUS control, and just one injection in the end. Because if there are micro dissection, you can open them up. Regarding the first question about a decay crash, obviously, if it's non-chip patient, then it's appropriately indicated. Decay crash is perfect. You have time, stepwise, as per each step, without any cutting corners, to have good result with imaging control. But quite often in those who are really cheap with low ejection fraction, I agree. Quite often you try to simplify the procedure. And
yes,
in the end of the procedure, if you have symmetry flow in the branch, that's all you need. And again, as mentioned previously, you can bring the patient back for control. And then if you have problems with the side branch, you can do other techniques. You can finish in a culotte fashion. You can do tap. Many options. But of course, if you have mechanical support in the case, then you can do proper decay crash in even those, like I'll show, with the ejection fraction of 10%.
Yes, my only important question: what is the role of POTS in cases of non-LMCA disease? You have done the case, you have given the POTS. Because Sumin Sharma and Kini, they published more than 5,000 cases of the non-LMCA. They are not used the POTS. So they mentioned that it is not a mandatory at all. What's your opinion in that view? Use of POTS in the non-LMCA disease. Bifurcation.
Yes, use of POT. I just didn't get the question. Use of POT.
Yes, utility of the POTS in cases of non-LMCA bifurcation disease.
Yeah. Use of performing POT in non-left main bifurcations.
Oh, yes. I always do POT in non-left main bifurcations in tapered vessel. Quite commonly, we're talking about cracks of the right coronary. POT is very important, especially at the area of the bifurcation at the couple millimeters that's just above the bifurcation, and in those cases I always do imaging.
Okay.
Very important, yes. Especially for recrossing wire with any technique you have, without doing POT. It's short term. On angiogram it will look nice anyway, but we're talking about long term.
Hello, Dr. Rustem. I have a question. The whole concept of this complex bifurcation techniques is because we are seldom able to place the stent perfectly at the ostium. So we pull them and do the decay crash, and we ensure that the ostium is covered. Now, what is your go-to strategy for ioto-ostial lesions? I mean, how do you approach that?
In terms of first part of your question, Scott Harding from New Zealand just recently published it. I was guided stenting of bifurcation. I really recommend you to read that. It's very good paper. In regards to your second part of the question, aorta-ostial, quite commonly in elderly patients, they will have a lot of calcium. I use rotablation or orbital atherectomy for this kind of lesions in preparation, because you are dealing with aortic calcium, not with the coronary calcium, and even shockwave sometimes it's not enough. So in those cases, obviously, we need to protrude a couple struts to the aorta and do perfect post-deal in those situations, if that's what you meant.
Dr. Verma?
Provisional stenting strategy, left main bifurcation, LMCA to LAD, normal LCX, ostium. To do kissing or not to do kissing. Again, the same provisional strategy in a non-left main bifurcation, let's say LAD diagonal, normal side branch, stenting only the main branch, provisional strategy, to do kissing or not to do kissing.
Okay, second part of the question, routinely I don't do that. If I stent the bifurcation in mid-LAZ with diagonal, then I obviously do good POT. And quite often we don't need imaging for those cases, just on experience on angiogram. I don't recross if the side branch flows nicely. First part of the question, in my fellowship, the teaching was we just provisionally treat left main to LAZ without opening struts of the circumflex, and quite often I still do that. But depends on the possibility of return and treat the circumflex, if it's retroflex, etc. Quite commonly, distal strut crossing with ballooning, with semi-compliant balloon, it's a good option, and finishing with POT.
Yeah, I think even in the left main, there is no benefit for systematic kissing balloon inflation. That is what the literature tells. Even a performance of an excellent POT has resulted in clearing of the stent struts from the ostium of the side branch and some evidences are coming from registry that TLR will be lesser in that situations. I think thank you, Rustem, for the nice
Thank you.
talk. We'll move on to the next topic.